put up with my crazy ass dogs. Sorry. Now we're lucky today. We've got Megan White, who's CNC at Concord Hospital, who's going to talk to us about restricted weight bearing in orthopaedics. So I'll hand it over to you, Megan. Thank you.
Okay, thanks, Paul. So what I'm going to touch on today is restricted weight bearing in orthopaedics. So these are our patients that aren't allowed to put their full weight through following an orthopaedic injury or surgery. So I guess the background for me looking into restricted weight bearing was just with the ageing population. We're seeing a growth in increased fragility fractures that are being admitted through our hospitals, with some of the common sites for fragility fractures being your hip fractures, upper limb fractures, so your humeral or your wrist fractures, lower limb like ankle fractures, and periprosthetic fractures, which is also increasing. So part of the methodology before we started looking at the looking at the restricted weight bearing was collecting data. So we became part of a clinical redesign project. So we collected patient stories. We looked at our length of stay in hospital. There were a lot of complaints about bed blockage and a lot of limited access to subacute care, and this could be part of their varying admission criteria. So we wanted to put it all together just to see where we're actually at. So with the patient's voice, I just wanted to start with a patient's story. So Joan was admitted to us. She was 75-year-old and was admitted with a fractured ankle. So her story was, she was out enjoying my day shopping when I fell over. It was so silly. I don't even remember what I tripped over. Everyone was coming over to see what had happened. I was so embarrassed. I just wanted the ambulance to hurry up. The staff in the emergency department were lovely. They gave me pain relief, and I met doctors who told me I'd broken my ankle. The staff were always lovely on the ward, making sure I felt okay. I've been on the ward for about 3 weeks now. I just cannot manage. I usually play tennis, so I'm not on it. I'm getting frustrated with myself. I keep telling myself, use your arms, push yourself, but I can't. I feel like the staff are feeling like, what are you still doing here? The staff run around, so I don't want to bother them. They really are nice, the staff here. I just feel like my whole life is still going on outside the hospital, like bills and everything, and I'm stuck here. So a lot of the patient stories that we had, we were still getting the same sort of themes. They were bored. They felt the days were long in hospital. One commented that she's lost her mentality. Another saying, I'd be happy to help my mother if you just showed me what to do. So we could hear the frustrations coming from the patients. We also interviewed the staff, finding out the nurses. So the nurses were talking about the lack of time. They felt that these patients were time consuming due to their inability to mobilise or mobilise independently. The occupancy, so they felt the ward was inappropriate location for the patients, with the average length of stay building up. They also felt that they could monitor the patient's deconditioning throughout their acute admission due to limited time allocated for mobility, sitting out of bed, regular pressure injury care, and ongoing management with pain relief. They also felt the mental well-being of patients, with 70% of nursing staff voiced concern for the mental well-being of patients and felt that patients were losing their confidence in reduced mobility and completing their everyday activities, which was a major issue following orthopaedic surgery. We also spoke to physiotherapy, occupational therapist, social worker. We spoke to the orthopaedic consultant, so rehab consultant, and orthogeri consultant. And we're all voicing the same frustration, that we felt that these patients were very time consuming, and we didn't feel optimising their management whilst they were in hospital. So the key issues that we did identify was the poor communication process. So even when the post-op notes were written, it wasn't always clearly the duration of how long a patient would be restricted with their weight bearing. Also the restricted weight bearing terminology. So whether the patient was non-weight bearing, touch weight bearing, partial weight bearing. So there was a lot of variation to what each surgeon and what each nurse felt that definition was. Also, they felt the poor communication with the patient and with their family. The patient's experience, so as we heard from the patient's story, the deconditioning, the boredom, they felt the reduced interaction with health professionals because the health professionals were busy. And delayed discharges. So there were so many variances in the admission criteria to subacute care. So subacute meaning your transitional care units, your GEM wards, your rehab wards. So while some areas would take non-weight bearers, others wouldn't. So it's very challenging as a clinician when you're trying to educate the patients about discharge planning due to the very strict admission criteria to these subacute areas. So we looked at what we wanted the patient journey to be. So when a patient would come in, whether it be with a fractured ankle, a fractured humerus, as soon as they were deemed restricted weight bearing, we developed a brochure. Now what this brochure did was it actually went through what reconditioning is, and then it explained the different types of weight bearing for the patient. So if a patient had been told they were non-weight bearing, the explanation was then given to them what is non-weight bearing, why are they non-weight bearing, and different techniques that they can use throughout their stay whilst they are non-weight bearing. The second part was looking at the agreed terminology. So when we looked at the terminology, we looked at our four main weight-bearing statuses that we had used over the couple of years that we looked at our data. So the non-weight bearing, where the patients weren't allowed any weight through the affected limb, whether that be an upper limb or lower limb. Touch weight bearing for the lower limb was where the patient was allowed to put their toe ground, and we used the example of walking on an eggshell. Partial weight bearing was where the patients allowed 50% of their body weight through the affected limb. And then another one was the protected weight bearing, which is basically weight bearers tolerated through the limb, but they always required a walking aid. So whether that be crutches, a walking stick, a pickup frame, enabled to protect that injury. Then we looked at having a family conference. So once we got all the surgeons on board to correctly document in the post-operative notes and the consensus was formed, then we decided ways that we could improve the journey for the patients. So this started with the family conference. So what would happen on the third day or fifth day, depending on when the patient was admitted, we'd sit down with the patient and we'd go through all their discharge planning with them. What this also gave us the time to do was establish for our patients. So this was a short-term goals or long-term goals. So when we looked at our short-term goals, the goals were tailored individually for our patients. We would look at a function goal for our patient. So a short-term goal may be that they can dress if they've had an ankle fracture, that then they can dress their upper limbs, or vice versa. We also looked at a mobility. So some of our patients, older patients, we'd find with mobility, what we looked at was a goal may be for them to become 1 assist or 2 assist, or be able to transfer in and out of bed. Some of our long-term goals included more advanced, so if our patients wanted to get home, what did they need to be able to get home? So this was independent transferring in and out of bed, or if our patients needed to go to subacute care, then we would look at what subacute care was available for that patient and establish their goals accordingly so that we could make a smoother transition to there. Also, with the discharge planning, we were able to go through with the patients where they were actually able to be accepted for their ongoing management. Then we started our reconditioning program. So what this ended up being was a 3-tier exercise and function program. So the reconditioning program consisted if our patients were on bed rest, if our patients were chair bound, or if our patients were up and walking. So that way we could tailor their exercise and their recovery to meet these goals. So the reconditioning program started. The occupational therapist and the physiotherapist with myself got together and developed a program for our patients. Once we developed the program looking at upper and lower strength and looking at keeping our patients conditioned whilst they are in hospital, what would happen then is the occupational therapist would come in 3 times a week and work on function with the patients. Sometimes they would be jointly done with our physiotherapist. So the occupational therapist would work one-on-one with the patient, again looking at dressing, looking at transferring. If the patient was going home, we even had an area set up in our gym where the patients could make cups of tea so that they could start to regain their function. The physiotherapist, we started an exercise class in our acute care setting. So what would happen at 10:30 every day, our patients would be taken down to our gym where they would do a circuit style exercise class. Now obviously the exercises were tailored to the individual. So majority of our patients, I think when we first started, 30 out of 31 attended the daily exercise class. Even our patients with cognitive impairment also came along and were actively involved in participating in the exercise class. So the exercise class not only helped our patients with the reconditioning, but it also encouraged our patients to socialise, and at times it became a little bit competitive as to where our patients were up to. It also gave the patients an opportunity to do stair practice and to work one-on-one with the physiotherapist as well. The nurses, so we gave a lot of education to our nurses, and what we looked at was in getting them to encourage independence. Again, dressing our patients every day. There was no more breakfast in bed, so all of these patients were up and moving around. They'd also encourage exercises. So when we'd take our patients back to their bedside, they would have exercises that they were to routinely do. And then if family members came in, family members were also trained so that they could encourage their family members to participate in the exercises. With the reconditioning, we also did FIM scores, which is a functional independence measure, just so that we could measure how our patients were going whilst they were participating in the reconditioning program. Our medical staff also, when we would round each day, were also encouraging our patients to participate. So some of the results to date was the staff satisfaction. The staff were happy that we finally had a model of care that our patients could follow. They were engaged and promoting a mobility and function. The staff encouraged patients to participate in the daily exercise class. We do around half an hour before the exercise class so that our patients could participate and be comfortable whilst they are. And The goals were written by the bedside patient, so the staff knew exactly what the goals had been set up for the patient and where the patient wanted to be. So the staff would assist the patients to reach these goals and keep encouraging our patients. With the patient experience, the patients were happy that they were given goals and encouraged when they met the goals. They found the interaction with the health professionals had increased. They also felt like they were getting their mentality back. They were given purpose on the ward, and this purpose was with their interacting with other patients that were in very similar circumstances with our experience. Patients also commented on how much they enjoyed speaking to the other patients as well. The other benefits was the improved communication with other local health districts. Just in our hospital in particular, we do have a large catchment of out-of-area patients. And what it really highlighted was how important function was to benefit these patients with their recovery. Some of the lessons learnt while we were looking at this reconditioning program was the open communication and regular updates to sustain the project. So it really was a team effort. All of us working together to for the benefit of our patients. The good data collection. We looked at 2 years of data for our patients. Again, evidence. There's not a lot in the literature to support whether a patient should be non-weight bearing, touch weight bearing, or partial weight bearing following ankle fractures, humeral fractures, etc. A lot of it was the senior nurses role modelling this behaviour. So this was a patient cohort that were often, because of time constraints from physiotherapy, were often not always the priority, with a lot of your fast surgeries that went through. And the importance of equal input to promote our optimal outcomes for patients. So when we were looking at this reconditioning program, we wanted to make sure every voice was heard from our patients, nurses, allied health, and our medical staff as well. We then, after we'd put all this together, we launched a model of care. And with the model of care came down a very definitive plan for our patients. So we incorporated all the brochures and the guidelines for our patients. And one of the patients actually reported back on the model of care. We invited him to come back. He was one of our first patients that participated in our reconditioning program. And he actually said to us that he didn't realise how beneficial the reconditioning was and the importance of the reconditioning until he got home and he continued doing his exercises. And he said, I looked back at my time in hospital and I realised that the exercise and the reconditioning program was what brought me through hospital, what kept sane in hospital, and what kept me alive to get me back home into my work, back home to my place. So there were a lot of people that helped us with the restricted weight bearing program. Okay. You
finished there?
Yeah.
Excellent.
Sorry, it's hard when nobody's talking.
Yeah.
Yeah.
So Christian's presentation, I mean, it's great to see some structure to that based on mobility, and I think that's really important because patients, like throughout my whole career in ortho, it's just one of those groups of patients that was just too hard, and you just thought, nah. But the default position is they sit in bed in the hospital and wait, and then by the time they get to that, the stuff you're talking about, by the time you get to a point where they're able to weight bed, then they're too far down the track, and they just suffer a long-term result of that as well.
Yep.
So Christian's written an essay here.
Yep.
I really think it's important. It's good. Measure the benefits and await precautions versus complications. Yeah, that's so. Even making that. So I guess what you're saying, Christian, is making that decision. Is it worth protective weight bearing them as opposed to the complications? That might be a better or worse outcome, and you might have them if you actually let them weight bear potentially as well.
Yeah, and I agree, Christian. And what I found was before the reconditioning, we probably sat at about 9% complication with these patients, and following the recondition, we've had 0% of complications. So it just shows the activity and the importance of reconditioning while these patients are under our care. But I do agree, more of a decision making. I mean, look at our fractured NOFs. I mean, it's rare for them to be non-weight bearing now, because we know the effect it had on them.
Yeah, so you make a judgment call, I guess, based on the the individual patient, don't you? And
Yep.
what's the potential complications of making them lie in bed for 6 weeks, or just bed to chair, compared to maybe there's a slight risk that something may happen surgically. So that's really important. It's a great topic, and I think it's great that you guys have been able to design a program looking at those patients, because that's one of the things really I saw in my practice, and I just didn't know where to go with it. I just thought that it's too hard, put it in that basket.
Yeah, and I think I've been complaining about it for so long that given the redesign, it was really good opportunity to, to look at your practice, and so that was our little logo, that foot there, that recover, recondition.
That.
Yeah. And so that's placed next to the patient's bed as well, that then we know this patient's on the reconditioning program.
It is important to have a logo or something that sticks out, because people identify with that stuff. So, did you have a competition thing to come up with the design, or
my husband actually drew it. So, but I wanted that jigsaw sort of, and then our marketing department at Concord put it obviously fancier and put it together. So,
okay, well, that's good. How did you go? I mean, I know this is potentially a lot of extra work for nursing staff. Did you have trouble at the start trying to get people to buy into that sort of that additional activity? Because the path of least resistance is just to leave someone in bed, or just pivot them on a chair or something, I guess.
That showed me how powerful the patient stories were.
Okay. Yeah.
Because when they were really talking, and the staff were frustrated too, because they were so over these patients just sitting there, and it was like, well, we've got a way to get them out, let's all work together. And that's where part of my role was, to actually come in and help them, move these patients. The physio were on board. I mean, the occupational therapist wouldn't routinely see these patients, and we got their involvement.
Yeah. Oh, that's good. So Kristen's going to give you a buzz. That's good. Oh,
yeah, absolutely.
And I forgot to say at the start, sorry, that you're the current president of ANZONA as well. I should have said that right at the start, sorry. So just so people are
That's all right.
That's good.
That's
so,
all right.
Christian, have you got any other questions? I just had while you're typing or thinking, Wendy just sent me a message. She hasn't been able to get home yet, so she's missed the webinar, sorry, so her apologies. But it's a really good topic. I think, and I know we've been talking about this for a while, but this is worth writing up for the journal.
Yeah, we've just started an ethics where we're actually, so then all our data, like the FIM scores, the rehab scores and everything, can actually be put together, including our patient stories. Yep. So I thought I'll probably publish this part as to where we're up to now, with then like the second part with the ethics to come.
Yeah. No, that sounds
to reinforce it, yeah.
I just think, I mean, as far as I know, I haven't heard of any other programs looking at this patient group, and this is an issue everywhere. It's not, it's not localized, so that'd be really interesting. I think people would be really interested in that model, all over the world. So that's worth, getting that written up. So let me know, and we can start, getting your writing together, and get that submitted. That'd be really good.
Yep, no problem.
And so Christian just said thanks for taking time. I hope you meet you at the next. Yeah, so Christian make it to the last conference. So
Oh, okay.
both be able to head over to Perth next year and make the conference over there as well.
Yep. Thank you, Christian.
All
Thanks
right,
for coming on.